Well, I'm Lawrence Robbins. Thank you for attending. This is the second case in my series, Neurology and Psychiatry cases. This is on Parkinson's and anxiety. You can email me for articles, etc. at lrob98@icloud.com. And this case revolves around John, who's a 68-year-old man with a year of tremor, bradykinesia, mild postural instability. He's on amantadine for all this. And he has a lifelong history of mild dysthymia, but severe anxiety with OCD. So I was going to give a little bit of an overview of Parkinsonian. That's the big tent of which Parkinson's is part of it. But there's 4 other issues under Parkinsonian that I'll go over. So first, drug effects. We see them, of course, acutely in the ER, often with IV prochlorperazine or metoclopramide, sometimes when it's given for nausea with migraines. And people can, the most common reaction is akathisia, just very restless. They go home, it's missed, and they're up all night pacing back and forth. On rare occasions, we can get dystonia. You can get segmental focal dystonia or generalized, but akathisia is a lot more common. Longer term with drugs, we get dyskinesias, which is basically the same really as chorea. We ought to just call them all chorea or dyskinesias. And if it's greater than 3 months, we call it tardive dyskinesia. So these days, it's usually from certain atypicals, but the penes don't usually cause dyskinesias very much or extrapyramidal side effects. Quetiapine, olanzapine. The original was clozapine, 1992. And then a few years later, the others came along. The penes, though, cause a lot of metabolic syndrome with increased weight, particularly clozapine and olanzapine. The newer ones, like cariprazine, don't tend to cause the weight gain or dyskinesias. And the penes and some of the newer ones, cariprazine, brexpiprazole, have minimal D2 effects. They'll work more at 5-HT2A, other serotonin receptors, D3, et cetera, et cetera. The older antipsychotics, the first generation, tend to cause more of the movement disorders and extrapyramidal effects, but less of the metabolic. The dyskinesias are usually oral and fingers. You have to ask patients sometimes if their tongue is moving inside their mouth. They might not volunteer it. Their fingers can be moving just like they're playing the piano. And after a while, some of your patients won't have movements like that, but they'll just look stiffer, less associated movements when they walk with their arms, maybe mild masked facies. And you can see it when you bring them into your office. Parkinson's plus syndromes, there's 3 main ones. First is PSP, which is a tauopathy. So not being alpha-synucleopathy, we're not going to usually get REM sleep behavior disorder. You might, but not usually. There's early Parkinsonian features with gait disturbance comes early. Most patients with Parkinson's, balance and gait are later. 70% of Parkinson's patients present with a tremor primarily. But with PSP, we get eye movement abnormalities. It might not be there in the beginning or be easily recognizable. It's mostly vertical gaze, at least to start, and more down gaze. As we get older into our 80s and 90s, it's harder to look up. With PSP, it's harder looking down. But retropulsion is common and can be severe. We do get early cognitive behavioral problems. Sometimes PSP is associated with frontal temporal dementia, sometimes with motor neuron disease. You can have dysarthria and dysphagia, and eyelid opening apraxia might be seen. It's a fairly rapidly downhill course. People don't do well. And unfortunately, outside of supported care for the patient and the caregiver and family, there's not any terrific medicines that can help. Next is fairly unusual corticobasal syndrome, or cortical basal degeneration is what's going on, that's discovered at autopsy. It's more of a tauopathy like PSP, and we get more cortical symptoms, apraxia, which is difficulty doing previously learned movements. You can have motor, you can have visual apraxia, but usually it's motor. So you can ask somebody to salute or drink from a cup. They may get sensory neglect, myoclonus, and alien limb. Alien limb, they just don't recognize and are wondering what their arm is or their leg. It's an unusual syndrome. They may have a dementia, usually will eventually get a dementia, but a dementia with Parkinson's itself usually comes after 6, 8, 10, 12 years. Not everybody with Parkinson's, if they live long enough, they'll get a dementia, but it may take well over 10 years. With cortical basal, we'll often get asymmetric Parkinsonian features, which is similar to Parkinson's. Parkinson's often presents more asymmetric with a tremor on one side. Now, multiple systems atrophy is a little different because it is an alpha-synucleopathy, so you may have REM sleep behavior disorder. They'll have a Parkinsonian type or cerebellar or mixed. They don't usually have a rest tremor. They might have a kinetic tremor, which can be confused with essential tremor then. But what the hallmark of most people with multiple systems is severe autonomic dysfunction, which you will find in Parkinson's also. But their blood pressure can go from 120/70 laying to 60/0 standing. So we want to check autonomic. We want to check for orthostasis. We'll have somebody lie down for a few minutes, check their blood pressure and pulse. They'll then have them stand for a few minutes, 3 minutes, do the same. Then after 5 minutes and 10 minutes, it can be delayed. So you can do actually fairly good. It's not as good as a tilt table, but not bad, which you can do in the office. There's a lot of other symptoms that multiple systems atrophy may have, such as dysarthria or dysphagia. It's relatively rare. There's a little over 30,000 people in the United States probably with MSA. Now, aging, people can look Parkinsonian. After age 85, half the people have Parkinsonian features, usually loss of associated movements. They look stiffer, festinating, small gait with small steps. They may not have the tremor. They don't have a rest tremor usually. But even after age 70 or 75, many people have Parkinsonian. If they have vascular insults, poor vascular health, they're more likely to have this. People become more flexed and hunched. And the Parkinsonia features at older ages do increase your risk for being frail and for falls and early death. There's a frailty scale that's useful. If people are moderate or severe on the frailty scale, they're more likely in the next 5 years to pass away. A lot of patients have Lewy bodies on the autopsy, but they don't have Parkinson's disease. But if they do have Lewy bodies, they're more likely to have had poor balance and falls before they died. And insults to the basal ganglia. The basal ganglia are insulted easily. They have a very dense vascular network. They have a lot of metabolic demands. So neurotoxic compounds really injure the basal ganglia easily. Maybe Agent Orange from Vietnam, heavy metals for sure. Manganese we talk about, but others. Certain designer drugs, MPTP, methanol, toluene, and certainly pesticides. Infarcts, both large and small, can affect the basal ganglia. You'll have your multi-infarcts, large ones, and then the lacunes, mostly from blood pressure not well controlled, which also affects the pons and thalamus as well. So as far as Parkinson's, what do we do outside of medicine with somebody like John? Well, we push physical therapy and exercise. Exercise is crucial. People do better. Anything that they can do. Of course, if we kick it up to moderate or more vigorous exercise, it will do somewhat better, but our goal is to just get people doing something. The type of therapy that therapists, and there's some specialists in this, will do is LSVT big and LSVT loud therapy, and it really works. People have to work at it hours every week, but they take longer steps. They talk louder, they write bigger. It really helps until the disease overcomes you. Psychotherapy is very important because of all of the psychological underpinnings that happen. I'll go over in a little bit. Support groups, mainly online, are very helpful. Boxing, non-contact boxing for Parkinson's. Occupational therapy and speech therapy can be very helpful. And we push social engagement. Parkinson's is, like a lot of our chronic illness, very isolating. It takes a village to raise somebody with Parkinson's, so we get other villagers involved. We always pay attention to the caregiver. YouTube is a great source for patients and caregivers. There's a woman, Teepa Snow, who has a channel on YouTube, and she's a wonderful lecturer. She's a caregiver and dementia expert. And the Parkinson's Foundation, Michael J. Fox Foundation, others. So Parkinson's, I mentioned, usually begins with a tremor. If it starts out with balance problems, retropulsion, it's going to have a quicker course and not do as well. There's many, many non-motor issues that are very important regarding disability. The entire body, really, head to toe. So the dementia I mentioned takes a number of years, unless it's dementia with Lewy bodies, DLB. And then you have the dementia early with hallucinations and fluctuations, early dementia, Parkinsonian features. And dementia with Lewy bodies is fairly common. Almost 1.5 million people in the country probably have DLB. Dementia is worse in those with Parkinson's who are older. Sleep disorders are very common, particularly REM sleep, as I mentioned. REM sleep is really, during REM, your body is supposed to be paralyzed, but here they're kicking out, kicking their partner, falling out of bed. They're not doing complex sleep eating, sleep walking, sleep driving. That's more between usually phases of sleep, 1 and 2, 2 and 3. But they'll also have insomnia with Parkinson's. REM sleep behavioral disorder can precede Parkinson's by a number of years. Parkinson's may very well start in most people in the GI tract, down lower. We have constipation in the 20s and 30s, and then it moves like a prion disease. These misfolded alpha-synuclein seem to cause the alpha-synuclein protein in the next cell to misfold, and almost like an infection. And it makes its way up the vagus nerve, and then the substantia nigra, of course, and the olfactory bulb are hit first. But you can lose a good 60% of your dopaminergic neurons in the midbrain substantia nigra and not have clinical Parkinson's. So by the time we get clinical Parkinson's, it's fairly advanced, the disease is. So if we ever do come up with a vaccine or treatment that might prevent it, we're going to need biomarkers. And biomarkers are really a key to Alzheimer's, to motor neuron disease. Basically, they have biomarkers. We want biomarkers that are not CSF, something easier than doing a functional MRI or CSF. So blood or saliva are ideal, or even a skin biopsy wouldn't be as difficult. We basically have biomarkers for Alzheimer's and Parkinson's. It'll take a little while to commercialize them, I think. So we also get skin changes with Parkinson's, with oilier skin. We'll get blepharitis because people aren't blinking. GI issues, as I mentioned, constipation and early satiety can be really severe. Drooling, urinary problems, we'll get sexual problems due to the autonomic dysfunction. Dystonias, more in the toes. You wake up with your toes all curled and painful. Now, cognitively, we have a lot of impairment. Almost all executive functions. With executive, I think of SOAP, sequencing, organization, abstraction, planning, and several others, judgment, etc. We get slowness of thought and decreased attention. Apathy is a major problem, and it's difficult to treat and to get at. Lower motivation is often seen. People just sit in their chair at home. There's a number of neuropsychiatric symptoms. Emotional dysregulation is very common. Impulse control, which can be worse or brought on by the medicines, dopaminergic medicines, more the dopamine agonists like pramipexole. So if you use them for restless legs, also you have to warn people if they're gambling in the middle of the night, that it's from the medicine. We get sometimes abnormal thought content, inappropriate social behavior, slowness of thought. People don't join in a conversation because their brain is just going too slow. So anticholinergics are sometimes used for the tremor. I don't love anticholinergics because of the risk for dementia and also falls, orthostatic hypotension, dryness, constipation. So in older patients, I tend to skip these. Amantadine, though, is useful. It has some dopaminergic effects. We don't get the dyskinesias. Pain is increased in Parkinson's. They'll get back and neck pain because they're hunched over. Evolutionarily, we weren't supposed to walk on all 2 feet anyways. But also people with Parkinson's, interestingly enough, are more sensitive to painful stimuli. So all of these non-motor symptoms add to the disability. If they have headaches, I did an entire headache discussion in case number 1 of this series. But triptans can be used. Gepants are ideal because they don't affect the heart at all. Unfortunately, L-DOPA, dopamine agonists, don't treat migraines, but one of the Parkinson's medicines, selegiline, which is an MAOB, which affects dopamine, but not serotonin nor epinephrine, it's a fairly safe medicine. It can help Parkinson's, depression, and headache. It usually helps Parkinson's only if you're on L-DOPA also. So our patient has Parkinson's with depression and anxiety. We need to address comorbidities. Depression is very common with Parkinson's, up to 50% of people. If we include milder forms of depression, we're always looking out for mild bipolar, which in case number 1 of this series, I talked quite a bit about the mild and the bipolar. Psychotherapy is crucial, supportive therapy. We push exercise, of course. Tricyclics, because of anticholinergic effects, can affect the tremor, but often they're not that well tolerated in older ages. Sometimes transcranial magnetic stimulation or even ECT are used for very resistant depression, but the usual are SSRIs and SNRIs, and we'll use them in the 70s, 80s, and even 90s. The depression, of course, is organic. With Parkinson's, you have decreased serotonin and norepinephrine in addition to dopamine. But also everything is affected in their lives. Social standing, they lose their job, relationships go down, functioning, and independence. They can't do very much after a while. It's a relentless and downhill nature, but people can have a lot of years of very good life first. Same with Alzheimer's. Apathy is a big problem. It's difficult to address. Psychotherapy might help. Levodopa can help the apathy, and sometimes modafinil or the stimulants can be useful. Certain antidepressants, SNRIs particularly, can help. And isolation and loneliness. We have an isolating society, which is more objectively measured. Loneliness is a little more subjective. Now, a lot of people are isolated, but they're not lonely. The problem is, with any chronic illness, and Parkinson's is certainly one, friends and family often drift away for various reasons. Women are a little more connected. Sometimes with Parkinson's, the person is talking very softly, and people say, I can't hear him at dinner, and it's too difficult, so they stop inviting the person over. Sometimes they're annoyed because the person is thinking too slowly. There's a lot of reasons, but people tend to drift away sometimes. Anxiety is a huge issue in Parkinson's. It fuels the depression, makes everything worse. So we'll push psychotherapy, exercise, yoga, and the usual medicines, SSRIs, SNRIs, and buspirone or gabapentin sometimes. Sometimes we'll use an antipsychotic if it's necessary, if people have psychosis, of course, and we'll choose the penes. I'll go into that in a little bit. Selegiline is the main MAOB I mentioned, and it can help Parkinson's if somebody's on levodopa, but it can also help moods. It's metabolized to amphetamine, so selegiline has been used with SSRIs. If you keep selegiline under 12 milligrams, you're not going to get very much in the way of interactions, etc. So psychosis is relatively common in Parkinson's in older patients after a number of years, particularly. If it happens early, we think more of dementia with Lewy bodies, etc. We look for hallucinations, which is something that's not there at all, like a little animal, a little person is common. Illusions are similar, but it's a play off something that's there, like somebody waves their hand and they'll see trails. Delusions, a fixed delusion, is actually can be part of psychosis, and that happens. Risk factors for psychosis and Parkinson's are many. Older ages, certain medicines, particularly dopamine medicines, anticholinergics, benzodiazepines, which we try to avoid, longer duration of symptoms, depression, particularly severe depression. Now, REM sleep behavior disorder is a risk for psychosis, but it's almost ubiquitous in Parkinson's. More risk factors, medical comorbidities, polypharmacy, anxiety, apathy, decreased sense of smell, sleepiness, poor vision, severe Parkinsonian symptoms, autonomic dysfunction, illegal drugs. So a lot of things have to be assessed if somebody comes in with new onset psychosis. We need to assess for medical problems. Do they have sepsis? Are they infected, dehydration? So we need to do a medical and psychological workup. I think that an MRI is usually indicated. Hallucinations, as I mentioned, there's no outside stimulus. And visual hallucinations are what's most common. You can get non-visual, hearing, sensory, olfactory, but they're not very common at all. Usually hallucinations are non-threatening, a small little animal or person. They can be increased at night. A lot of patients talk about something like bugs crawling on the wall. And outside of medicine, we try to work with a room, similar to people with Alzheimer's, to try to adjust the room and lighting. We'll use behavioral techniques, distraction. They can be fearful. And the psychosis often drives nursing home placement. Passage hallucinations are where people feel like somebody's just briefly passing in the corner of their vision. Presence hallucinations, they feel that somebody is nearby, just hanging. Delusions are tough. You have to basically segue away and not argue with people. This happens quite a bit in Alzheimer's patients. And early in Parkinson's, patients have the insight. They know the hallucinations are real or not real. When it's more advanced after a number of years, it's tough for the patient to distinguish. Sometimes we get delirium with acute confusional states, which overlaps with this, may occur, and symptoms may fluctuate. Delirium is usually a problem with the head on top of a problem with the body. So we have to look at infection. We have to look at liver and kidneys. So the pathophysiology of psychosis and delirium is complex. We have drug-induced or we have intrinsic psychosis. And management, we try to minimize medicine, particularly dopamine medicines, but that can be tough to do. We work with caregivers and family, music therapy sometimes, configuration of the room, as I mentioned. Medicines, we'll use the penes mostly as far as antipsychotics, clozapine. There's one more designed for Parkinsonian, pimavanserin, Nuplazid. It's an unusual atypical. It works mostly 5-HT2A and others, and not so much dopamine. So we don't want to make the Parkinson's worse. Brexpiprazole now has an official indication for agitation in Alzheimer's, and that's been a newer atypical that's useful. Other possibilities, occasionally ECT, deep brain stimulation. There's no great evidence that it treats the psychosis. It treats other symptoms with Parkinson's. So back to our patient, because of the OCD, you might have to push SSRIs to high levels. SSRIs are reasonably well tolerated in older patients. And if dyskinesias happen, the L-DOPA might have to be lowered. We might use amantadine in these situations. I think I'll stop here with our second case. Thank you very much for listening.